Motor neuron disease is characterized by a relentless progression. Over time, localized electrical pathways systematically darken and fail across the human body. Clinically, motor neuron diseases, or MNDs, are a heterogeneous group of neurodegenerative disorders that cause progressive skeletal muscle weakness. These diseases selectively destroy motor pathways. Patients remain cognitively intact, and their sensory and autonomic networks are entirely spared. Despite all causing muscle weakness, MNDs present with contradictory physical signs. Some patients become locked in severe spastic rigidity, while others develop a profound flaccid paralysis. To understand why the same category of disease produces such opposing symptoms, we have to map these conditions directly to their specific anatomical points of failure within the motor axis. All voluntary human movement is driven by a strict two-neuron relay system. The upper motor neuron originates in the cerebral cortex, crosses the medulla, and descends the spinal cord to the anterior horn. Here, the central nervous system synapses with the peripheral nervous system. The lower motor neuron begins at this synapse. It acts as the final pathway, carrying the electrical signal out of the spinal cord directly to the target tissue. The relay ends at the neuromuscular junction, where the lower motor neuron releases neurotransmitters to trigger physical muscle contraction. Because motor control requires this exact sequence, the anatomical altitude of a lesion dictates the resulting clinical phenotype. Breaking the upper wire produces a distinctly different presentation than breaking the lower wire. The upper motor neuron initiates voluntary movement, while simultaneously providing constant active inhibition to local reflex arcs within the spinal cord. When an upper motor neuron lesion occurs, the lower motor neuron is left intact, but vital descending inhibition is lost. The local spinal reflexes are unleashed. Without cortical regulation, runaway reflex arcs cause hyperreflexia, locking the muscle in a continuous state of rigid spasticity. During a clinical examination, this manifests as pathologic reflexes. Clinicians look for signs like clonus, a rhythmic, involuntary muscle contraction, and the Babinski sign, where the plantar reflex extends upwards instead of curling down. This specific pattern of isolated upper motor neuron failure characterizes primary lateral sclerosis, or PLS. Patients with PLS develop slowly progressive stiffness and clumsy movement and pseudobulbar affect, involuntary bouts of crying or laughing, without profound muscle wasting. Upper motor neuron failure does not stop muscles from firing. It removes mechanical modulation, trapping the patient in the rigid overactivity of their own reflexes. If we move down the near axis to the anterior horn cells and the lower motor neurons, the pathology reverses. Destruction of the lower motor neuron physically severs the communication wire between the spinal cord and the effector organ. The immediate gross clinical consequence is flaccid paralysis and absent deep tendon reflexes. Without electrical stimulation, the muscle tissue rapidly shrinks, resulting in profound denervation atrophy. Deprived of nerve input, the orphaned motor units become irritable. They spontaneously misfire, creating visible, rippling twitches under the skin, known as fasciculations. This exact phenotype maps to pure lower motor neuron diseases, such as adult-onset progressive muscular atrophy and pediatric spinal muscular atrophy. This destruction removes all electrical drive. It leaves the effector organ to wither and randomly misfire in isolation. The most aggressive and fatal of the motor neuron diseases sits at the intersection of these two failures, amyotrophic lateral sclerosis. The defining hallmark of ALS is the simultaneous degeneration of both cortical upper motor neurons and spinal lower motor neurons. This dual pathology creates conflicting clinical signs within the exact same body segment. A clinician might examine a patient's hand and find profound muscle atrophy, a clear lower motor sign, while simultaneously eliciting a hyperactive Hoffman's reflex in that same limb, proving upper motor damage. As the disease progresses, it often attacks the bulbar nuclei in the brainstem, causing a complex mix of spastic and flaccid weakness in the muscles governing speech and swallowing. Overpowering upper motor spasticity can easily mask underlying lower motor atrophy. Because of this, ALS remains a severe diagnostic challenge on a standard physical exam. The neurological exam relies on detecting macroscopic structural failure. It misses early, masked disease. Neuroimaging is often included in the diagnostic workup, but its role is strictly exclusionary. Scans are used to rule out structural mimickers, like cervical spondylotic myelopathy. Standard MRI cannot diagnose ALS. It does not have the resolution to visualize cellular-level motor unit death. To find evidence of this cellular decay, neurologists use electromyography, or EMG, a tool capable of probing subclinical neurodegeneration that is invisible to the naked eye. An EMG involves piercing the skin with a fine needle electrode and advancing it directly into the skeletal muscle bundle to record localized electrical activity. To confirm ALS, clinicians must look past the gross anatomy and directly measure the electrical distress signals of dying tissue. In a healthy baseline state, skeletal muscle at rest is electrically completely silent. This readout shows an EMG trace. When a lower motor neuron dies, the silent baseline is interrupted by sharp, erratic electrical spikes, indicating active denervation. These spikes, known as fibrillation potentials and positive sharp waves, represent the spontaneous firing of orphaned muscle fibers. As the pathology advances, a secondary finding emerges: chronic neurogenic change. Surviving motor neurons attempt to rescue the orphaned fibers by sprouting new collateral connections. On the EMG readout, this vesicle spouting translates into giant polyphasic motor unit action potentials. Because a single localized injury, like a pinched nerve, could mimic these electrical spikes in one limb, a diagnosis of ALS requires proving that the disease is systemic. Neurologists must find these signatures of death across at least 3 distinct regions of the motor axis, confirming the degeneration has spread through the spinal cord. By utilizing electrophysiology, clinicians can detect cellular death, chart the exact anatomical spread of the disease, and differentiate ALS from its mimickers to provide a definitive, if devastating, diagnosis.